Welcome to ICU Primary Prepcast.
Hi, I'm Maddie.
Hi, I'm Swapnil. And today we're joined again by our celebrity guest, Mike Clifford from Melbourne. How are you, Mike?
Very well, thank you, Swapnil. How are you, Maddie?
Yeah, good. Good, can't complain.
Yeah, how's your preparation for Christmas going on, Mike?
It's good. All of my parcels are on the way, Swapnil. They're all coming either Australia Post or FedEx, so hopefully they'll all be here in time.
Oh, wow. That's very organised of you.
That's right. So good luck with that. So let's dive into today's podcast. So we're going to start with the case scenario. So over to you, Maddie.
So the next patient we're going to be talking about is a 72-year-old lady who has had a Hartmann's procedure because of perforated diverticular disease and had quite a complicated course in ICU with this abdominal catastrophe and being slow to progress. We've decided to commence her on TPN. Mike, can you tell me a bit about the pharmacology of TPN?
Yeah, sure. So, we often see patients with stuff hanging beside them, and we've added TPN into the curriculum. And on face of it, you think, the pharmacology of this fluid is difficult, but in fact, it's actually relatively straightforward. If you break it down into the usual principles of pharmacology, we've got a substance that has some pharmaceutics, some pharmacokinetics and pharmacodynamics, and just consider breaking it down into those categories. So first of all, if we have a look at the TPN that's hanging, there's two bags that we can see there. There's the electrolyte and amino acid solution, and there's the white lipid containing solution. So if we start with the amino acid solution, it's a intravenous solution in plastic. Sometimes it has to be protected from light because some of the water soluble vitamins are light sensitive, and it's made up to a prescription for the patient's nutritional needs, and that's a function of their metabolic rate and their metabolic requirements for ongoing wound healing or repair. We might make an adjustment for their underlying nutritional pre-existing comorbidities or status, and then we would have some stress factors that the dietitians would help us add in. And we come to an amount of protein, fat and carbohydrate that this little old lady will need. Now, we're going to give her some carbohydrate and protein as amino acids in the intravenous solution, and that we're going to give that continuously intravenously. Now, it's usually a hyperosmolar solution, so we often, but not always, need to give it centrally. So that's why she's got a central line in there. And we can see this particular formulation, there are many out there. Some of them come all pre-mixed from pharmacy. Some of them come as septated bags where they run separately and then join each other in the line, because if you leave the intralipid and the TPN to mix for a long period of time, sometimes the amino acids and the fat can undergo reactions together and you can get saponification and stuff. So often they're kept separate. In this particular case, we're giving them that fluid, and it's got the amino acids and the dextrose containing solution, usually at 12 to 15%, so that we can give her total carbohydrate requirements for the day. Now we can break it down into pharmacogenic. So it's being given intravenously, so it's got a bioavailability of 1, if you like, and it will be distributed over total body water initially, so a litre per kilo, and then eventually it'll be taken up by all the cells of the body and then metabolised. So, eventually it's got a terminal distribution that is much, much greater than total body water because it's metabolised. And the carbohydrate component will be metabolised as CO2 and water using oxygen, and the amino acids will be broken down into their constituents in the liver. And as we know, the amino acids have a carbon chain. They have an amine end and a carboxyl moiety at one end, and they'll often have aliphatic or aromatic components attached to them that will be metabolised separately via biotransformation within the liver. But the carbohydrate component of it will be redistributed through the TCA cycle, and it'll generate energy just like carbohydrate would. And the amine end will be combined with carbon dioxide to form urea and then excreted in the urine. So that's the sort of end product of all of the amino acids in the solution, if you like. And the dextrose is metabolised, as we've already discussed. So there are some specific contents of that solution. As I've already mentioned, there's often water-soluble vitamins, the B and C group vitamins. There'll also be some trace elements, in particular selenium and zinc. Some of the amino acids will be the essential amino acids, which are ones that we can't produce ourselves, for example, threonine and isoleucine. They'll be incorporated directly into proteins where proteins are manufactured in a cell. So we don't make those amino acids ourselves.
Tell me a bit about the lipids that are involved.
Okay, so the lipid bit's always, I think, a slightly more interesting solution because it's sitting there like milk in the syringe, and that's because it's an oil-based solution. So again, it's got water and it's got fat, and the reason it doesn't look like oil floating on top of the water is that it's got an emulsifier. And you see this all the time in ICU whenever we look at an ampule of Propofol. It's exactly the same when we look at intralipid or whatever the lipid solution used in your unit is, whether it's a soy-based or olive oil or fish oil-based solution. It will have an oil component and a water component, an emulsifier, often a stabilizer or a bacteriostatic or bactericidal content. There'll be something to stabilize the pH and something to make it isoosmolar. And the oil of choice is usually a function of the cost to the hospital. But we are transitioning away from the soy oils towards olive oil or fish oil-based solutions. The only other interesting component of those intralipid solutions, or lipid solutions rather, is that they have fat-soluble vitamins added to them, which are vitamins A, D, E and K. And often in Aviva, we'll get people to describe what those vitamins are important for.
It's also important, I think, with the fat-soluble component of it that sometimes we adjust the requirements if they have a lot of propofol. So some of the patients who are on large amounts of sedation, they are getting some of those calories from propofol, and that fat-soluble fat portion of the TPN looks a bit like propofol.
Yeah, that's right. Well, 10% intralipid, if you like, has got 1 calorie per mil. So if you're giving, 40 mils an hour, you're giving quite a lot of calories. And that needs to be taken into consideration. You're quite right. So, May, why don't you tell me a little bit about some of the more of the detail about carbohydrate metabolism? The carbohydrate that we're giving this patient as the sort of 12% dextrose, what happens to that?
So the carbohydrate portion, as you mentioned, it's a bit different from what we get from our normal oral diet, as in they don't need to go through the same initial absorption process through the mouth and the stomach. But it all ends up as glucose initially at the end of the metabolism process. And the glucose is then metabolized glycolysis firstly, which is a series of 10 chemical reactions that are catalyzed by specific enzymes. And this converts glucose into pyruvate. And this glycolysis process doesn't actually gain much energy. So the net gain is 2 ATP from that. So it's not a very efficient process initially to get energy. The next stage is this pyruvate that's made from glycolysis is then moved from the cytoplasm of the cell into the mitochondria, and then it's converted by pyruvate dehydrogenase into acetyl-CoA. And this occurs in the presence of oxygen. Otherwise, it tends to enter an anaerobic pathway. When acetyl-CoA is formed, it can then go by the Krebs cycle or the TCA cycle that you mentioned to form more energy. So this is a series of chemical reactions in which the oxidation of acetyl-CoA occurs to produce energy. And it's a self-perpetuating cycle. But this cycle only forms 2 ATP as well. The next stage of metabolic process is oxidative phosphorylation, which forms the majority of ATP. And this is a series of enzymatically catalyzed reactions which also occur in the mitochondria, which forms a lot of ATP and thus a lot of energy, but requires the presence of oxygen.
Okay. Where does all that oxygen go? What part of the mitochondria?
I don't know, actually.
Oh, okay. Well, there's those little buds on the inside of the mitochondrial wall where the cytochrome enzymes are. So the oxygen and its electrons get trickled along that and finally get converted to water and CO2 at the very end. So that's the final common bit of the mitochondrial pathway. So what's the difference if we started this woman on some oral feeds tomorrow and they wanted her to have sips and we started giving her some glucose, how does that metabolism differ? Or if we gave her some carbohydrates, say complex carbohydrate?
So the end stage is the same pathway, which is the same Krebs cycle and then oxidative phosphorylation. But the initial process is a bit different in that it requires digestion and absorption to occur. So that occurs firstly in the mouth with saliva, which contains something called petalin. I don't know how to pronounce that. Petalin, which is a digestive enzyme that's secreted by parotid glands. And this hydrolyzes starch, which starch is a complex carbohydrate, and it makes it into smaller molecules or disaccharides. So it makes it into some maltose and other small polymers of glucose. And then this digestion then continues a little bit in the stomach, but most carbohydrates, the digestion occurs in the small intestine. And this is via pancreatic secretions, which contain alpha amylase, which is much, much more powerful than that same amylase or talon that's in saliva. So when the stomach contents or chyme empties from the stomach into the duodenum, it mixes with this pancreatic juice and most of the carbohydrates is digested, and all these polysaccharides are converted into monosaccharides and then into small glucose polymers by the time it reaches the upper jejunum. Once it's in the jejunum, there are enterocytes that line the villi, and these contain many enzymes, which include enzymes like lactase, sucrase, maltase, and alpha-dextrinase, which then further splits some of the disaccharides, such as lactose, sucrose, maltose, into small constituent monosaccharides, which are mainly glucose, but a little bit of galactose and fructose. And then all of these monosaccharides are water-soluble, which can then be absorbed into portal blood. And then the glucose itself, the absorption process is quite interesting, as it's an active transport process with sodium, which occurs through the basolateral membranes of intestinal epithelial cells into the blood. So it's an active transport process with sodium that's combined with glucose, and then it transports it into the blood and then eventually to the liver, where the rest of the metabolism occurs, as we've mentioned earlier.
Okay. So how does it get into the liver? If it's actively transported up from the gut, what about when it moves into the liver cell? Is that active or passive?
So the liver and the brain are like the two of the main organs that don't require insulin for like GLUT4 transporters to help co-transport glucose into their cells.
Okay. And so what happens to the glucose that goes into the hepatocyte?
So then it starts, some of the other metabolic pathways that we've discussed before occurs. So glycolysis firstly, and then pyruvate's formed, and then once again into the Krebs cycle, and then into the oxidative phosphorylation.
Sure. What's the respiratory quotient when you're consuming pure carbohydrate like that? Or is it 1?
I'm going to go with 1 because so 0.8 is a normal diet.
That's right. Right. Yeah. So it gets pulled down by the fat and the protein, doesn't it? So where do those numbers come from? Why are they different?
So respiratory quotients, amount of carbon dioxide produced divided by the amount of oxygen absorbed. So I guess the amount produced per dietary substance is different.
Yeah, exactly right. So because you've got other elements in those molecules. So once you're down to glucose, it's basically carbon and water and oxygen. So the ratio of oxygen consumption to CO2 production is roughly 1-to-1, whereas the amino acids tend to be contaminated, if you like, by other components. So for a given gram, you don't get the same amount of CO2 produced. And similarly for fats, they've got a glycerol molecule at one end, and they've got other sort of phosphates and things in them. So they tend to be less tidy when they're consumed. So for any given molecule, you don't get the same ratio of CO2 to oxygen consumed. So that's good, Manny.
So, Swapna, we've covered a bit about TPN and the metabolism of carbohydrates. And going back to our patient, if we're trying to calculate their TPN requirements, something that's sometimes important is their basal metabolic rate. Can you tell us about what basal metabolic rate is?
Thanks, Maddie. So obviously this question has been asked in a primary, and then often candidates struggle to answer this question. The basal metabolic rate is the energy output required to sustain life at rest. That's kind of in a nutshell the definition. Now, how do you define the resting in different ways? So the individual who is fasted for 12 hours is in a comfortable external environment, and the individual is at complete mental and physical rest. And normally the basal metabolic rate is calculated at 70 kilocalorie per hour or 100 watts per day. Now, comparison to basal metabolic rate, the metabolic rate alone is the actual energy consumption by an individual, and usually is greater than BMR due to number of factors.
What kind of factors influence the metabolic rate?
Yeah, so the first and foremost factor is the age. As we all know, the BMR decreases as age increases, and often the neonates will have BMR twice that of an adult. Now, children will also have an increased BMR relative to that of an adult. And every decade of life, BMR decreases by 2%. The second factor which affects BMR is body composition. So the lean muscle has a greater energy requirement than fat. And so the higher body percentage of fat results in lower BMR. So often there is a kind of myth or notion that obese patients will have higher BMR. That's not actually true. Similarly, females will have lower BMR for the same reason. The third factor is actually the diet. So digestion increases BMR by 10% due to energy required to assimilate nutrients. Obviously, this is known as, and this is taken from Life in Fasting, thanks to Chris Nixon, as specific dynamic action of food. And often the energy consumed to metabolize protein is more than that required to metabolize carbohydrate and more than that required to metabolize fat. And interestingly, with the starvation, you will have decreased BMR because you're not eating. So the body doesn't need to spend any energy in metabolizing any of the nutrients. So starvation also affects your BMR. On the contrary, if you are exercising, the skeletal muscle has very high demand for energy consumption. So obviously your basal metabolic rate will be higher. Similarly, if you are in a cold climate, then that will increase BMR. And while in a temperate climate, the BMR is decreased up to 10%. In physiological states, for example, pregnancy, lactation, or with catecholamine release like stress, the BMR is usually increased. Particularly with the pregnancy, the BMR is increased up to 20% in second and third trimester as expected, because obviously you need more energy as the fetus is growing at the same time. In terms of the disease states, all the disease states that we see in ICU where there is hypercatabolic states such as sepsis or malignancy or hyperthyroidism will have increase in BMR. So these are the kind of main factors which affect BMR.
That's great. And are there any methods to measure or calculate this metabolic rate?
Yeah, so I guess the BMR can be measured either via direct calorimetry or indirect calorimetry. Now, the direct calorimetry is a very cumbersome process where individual has to go inside this room and then the total heat consumed and total heat radiated is calculated. And obviously, sometimes moving our ICU patients in those rooms is impossible. So often we use indirect calorimetry in ICU to calculate BMR. So I guess the way it calculates BMR is usually the heat production is assessed via measurement of VO2 and VCO2, so oxygen consumption and CO2 consumption. And number of methods exist depending on whether the patient is intubated or not intubated, and whether they are requiring supplemental oxygen or they're not requiring any oxygen. And often with a ventilator, we use something called as metabolic cart, which is attached to the ventilator, and that calculates your O2 consumption and CO2 production. But again, the conditions assessed by BMR are patient should be relaxed and fasted. So obviously you have to turn the feeds off at least for 12 hours. Then FiO2 needs to be calculated, taken into consideration. And then you measure the end-tidal CO2 and end-tidal oxygen. And then steady state should be achieved across the 5-minute period. And that will give rise to VO2 and VCO2 values. And based on that, you can calculate your respiratory quotient. Patient has to be in the horizontal position. There should not be any muscular activity going on. And the ambient temperature should be around 25 to 30 degrees Celsius while you're calculating the BMR. And I guess you can use the resting energy expenditure using the Harris-Benedict equation, REE. There are two different formulae for male and female. You probably don't need to remember the formula as such, but you need to think what are the kind of key components of that equation. That includes mainly weight in kilogram, height in centimeter, and age in years. So they're the kind of three main components of Harris-Benedict equation. Based on that, most of the dietitians use this formula to calculate your resting energy expenditure. And based on that, they calculate what are the caloric goals for individual patients. A lot of people might not know that you can actually calculate cardiac output as well based on indirect calorimetry, based on the fixed principle.
Would you be able to tell us are there any advantages or disadvantages of using indirect calorimetry?
In disadvantages to start with there are multiple sources of errors. Inaccuracies can arise from, say, air leaks. Like, for example, there could be circuit leak in mechanical ventilator or could be pneumothorax. The error will be there when there is an error in recording FiO2 or minute ventilation. And also some of the times the O2 sensors can be faulty, and that will obviously affect the indirect calorimetry readings. Now, the PEEP itself can alter the ventilatory circuit compressibility, and that might change the volume measurements, and that can affect your indirect calorimetry readings. So it is very difficult to use with uncuffed tubes, especially in children, and over or underfeeding may actually occur based on the results. So that's one of the disadvantages with indirect calorimetry. And most of the trials which have done so far using indirect calorimetry has shown that it really doesn't affect the outcome in terms of mortality benefit or morbidity benefit. Advantages, I guess it at least gives some sort of idea about what's the patient's oxygen consumption and CO2 production, and help us to at least have some sort of goal. And based on the trend or the values which we get by monitoring, not every day, but every third day, fourth day, or every week, at least we get a trend and whether the patient is reaching to his or her nutritional goals. While using the Harris-Benedict equation, it's very difficult to calculate those demands, because in initial part of the ICU admission, patient might be very hypercatabolic, and as they get better, they might become less catabolic. And that obviously that factor is not considered in Harris-Benedict. So obviously indirect calorimetry can be very useful in that regards.
Yeah, that's great. And I think it's thought to be more accurate in extremes of obesity and age, and it doesn't depend on some of the predictive equations, like you said. But like you're saying, it's not associated with any clinical benefit, and it's measuring a consumption, not necessarily demand.
That's correct.
It's great basic sciences, and you can see why it's part of the syllabus, because if you're standing at the end of the bed, you're looking at a patient who needs some nutrition, and everyone says, well, how much do we give them? And the default is to say, oh, well, we need to give them so much water and so much fat and so much protein. And then you break it down into, well, why are we giving them this much fat or that much fat? And you can have a discussion about how fat is more calorie dense than carbohydrate. So you can, if you don't want to give her so much carbohydrate so she doesn't make so much CO2, you can give her more fat, and you're giving her a different respiratory quotient, so there'll be less CO2 production, and that might make it a little bit easier to ventilate her, or if she's spontaneously ventilated, she won't have to breathe as much. So it's that marginal patient where a discussion of some of the nutritional factors is important. And we write up TPN prescriptions every day. So this is just bringing it back to why we're bothering to do this sort of stuff. And you'll often see people asking, you'll see a dietitian's formula in the chart and a recommendation for the total energy expected, and therefore what the goal feeds are and what composition they should be. And this just tells you why these things are being done for your patients. And the reason it's in the syllabus is to give people a greater understanding of some of the complexity and some of the limitations around those estimates, because whilst we do all of this stuff, there are some assumptions that go into them. And as an intensivist, it's good for you to know why they're there.
Yeah, absolutely. I guess dietitians are there to help you, but at the same time, I think having a basic understanding of the nutritional physiology is really important. So thanks, Maddie, and thanks, Michael. Coming to the last part of the podcast, which is Maddie's joke. I just want to remind Mike about the scores. Yep. We are at 2-1 at the moment. So let's see whether Maddie can do it.
It's like the Bulldogs in the grand final. Maddie is just kicking away here. It's the final quarter, and she's just banging on the goals. And I'm crying into my beer.
Oh, no. Okay, I've got one carbohydrate related today.
Cool.
So what did the umpire say to the sugar molecule that came second in the race?
Oh, hang on. I'm thinking. No, go on.
Sucrose, yet so far.
That's not bad. Yeah, you would have got that one. That's good. That's very good.
So can you explain that for people like me?
It's just like a play on words. Oh my gosh, seriously, I have to explain this. It's because sucrose is sugar, but sucrose sounds like so close.
And it's so close.
And it's so close yet so far. Get it? Now?
If Maddie has to explain the joke, I'm not sure she should get a score.
I don't know. I think that's more a reflection on Swapnil than anything.
Perhaps that's true.
That's right. Some people don't play footy and then they just don't understand footy. That's okay. So thanks, Mike, and thanks, Maddie. So we'll be back in month's time with another episode. So till then, goodbye and have a safe time.
Okay, see you later, guys.